Hello, everybody. Welcome to our QTHealth831 live stream. My name is Jacob Agamau. I accept any pronoun used with positive intent, and I am the LGBTQ plus services coordinator at the Epicenter. Before we get into our live stream content, I wanted to introduce my colleague, Haley Gomez, to tell us more about what we do at the Epicenter.
Hi, everyone. I'm Haley. I use they, them pronouns, and I work at the Epicenter as their media content creator. The Epicenter has many resources with employment and health and wellness. We help with creating resumes. We connect our youth with local services and help our students register for college. Also, we have numerous programs, one of them being the Friday Night Live program, also our Gente 831, the Youth Council, and California Youth Connection. So if you need any more resources with foster youth, housing, employment, education, feel free to reach out to us and visit our website at epicentermonterey.org.
Thank you for that. Like Haley said, you can learn more about our programming at epicentermonterey.org. And today we will be talking about masculinizing hormone therapy with a presentation by Dr. Rose Lovell. And we'll be hosting a live Q&A after that, so stick around if you have any questions. With that, I'm going to introduce Dr. Rose.
Hey guys. Hi. So I'm Dr. Rose Lovell. I'm a family medicine doctor. I'm one of the resident physicians who works at Natividad Family Medicine Residency. I work at the Natividad Hospital. And then I also work at Lovell Family Practice. If you want more details of what a resident is and all of that kind of stuff, go way back to our first video where I introduce myself and I explain all of that. But as part of our ongoing series, I'm going to give you kind of an intro to masculinizing hormones for trans folk. So let me click. So welcome. First of all, any medical talk you see will have a disclaimer like this. I'm not being paid by anybody to do this. I have no financial ties to any specific medical treatment that I discuss. I take no money from big pharma, so to speak. The views that I express are my own. They are not necessarily the same views as my hospital or my residency program or my clinic. I do my best with terminology, but also want to recognize that different people prefer different terminology. So I apologize ahead of time if I use terms with which you are not entirely comfortable. I try to stick to the medical terminology where I can. And then just so you know, information that I provide here is really informational only. It doesn't constitute medical advice. And the best thing, if you have very specific questions about your care, is to talk to your doctor. If you need help finding a doctor, that I can definitely help you with. We do have doctors within Monterey County who do hormone therapy, including at Lovell Family Practice. But really, if you have medical questions about your medical care, you need to ask your doctor. So masculinizing hormones in a nutshell. If you remember when we talked about a couple of months ago, more than a couple of months ago, and really I should acknowledge it has been a few months since our last presentation. And I want to thank you all for your patience with that. That again was related to a lot of COVID related care. But I'm back now and we'll be back on a more regular schedule. So way back when we talked about the basics of accessing hormone care, these are the same requirements. So in general, in order to get masculinizing hormones, testosterone mostly, really only, really you need to be either 18 or over, an emancipated minor, or you need to have your parent or legal guardian's consent, all of the legal guardians that are involved. And you have to be able to understand the risks and benefits of hormone therapy. You have to be able to express that understanding in some way and consent to the treatment. Those are the only actual hard and fast requirements in order to get testosterone. We do recommend in general that you have some kind of access to psychotherapy. There are some psychological changes that happen with hormone therapy. And I just, from my own perspective as a physician, I like to know that if you run into any personal snags, or you run into snags with other people not understanding what's going on with you and being transphobic at you, that you have access to some kind of psychological care. But being in active psychotherapy is not a requirement for hormones. It is recommended that other medical conditions be under a reasonable amount of control. So if you have diabetes, that doesn't mean you can't have testosterone. What that means is it's probably a good idea to try to have that under some reasonable control, but we can talk about that. It does put you at higher risk, but it's not a hard no. And then definitely recommend that you think about fertility, your own fertility, whether you want to have your own genetic children or not, whether you want to store your gametes, that is if you have ovaries, your eggs, or if you have testes, your sperm, in order to have genetic children in the future. Because the moment you go on hormone therapy, we cannot guarantee that you will preserve any fertility that you started with. So, basics. In terms of masculinizing hormones, we have one option and one option only, and that's testosterone. For the nerds out there, that's the testosterone molecule. Shamelessly borrowed from Wikipedia. So other basics when it comes to hormones. So the testosterone takes time to work, and I'll walk through that time frame and walk through all the changes that happen with testosterone. If you've gone through puberty before, it's a second puberty all over again. Permanent changes start to happen around 6 months, but really it'll take 3 to 5 years for all those changes to happen. If you have questions about like how fuzzy am I going to be, or what other changes are going to happen, am I going to go bald? Look at your closest genetic relatives if you know who they are. Your genetic, cisgender male relatives are usually the people I point at, but whoever's relevant. Sometimes you'll hear people talk about, well, this type of testosterone is better than that type of testosterone. We have no actual scientific studies to support any of that. So really, it's a little bit more of what works best for you. And your mileage will vary from everyone else. If you talk to any other folks who are taking testosterone, what works for them or what results they've had are going to be different from yours. And as a reminder, if you have a California-based healthcare insurance, so Medi-Cal, CCAH, any commercial insurance based within California, Anthem, United, etc., testosterone legally has to be covered by California-based insurance companies. It's California law. So what effects can you expect? This table is from the WPATH, the World Professional Association for Transgender Health Standards of Care. I love it. It's available in Spanish too, for those of you who feel more comfortable reading in Spanish. This is your effects and expected time course of testosterone. So you should get more, unfortunately, more acne is to be expected. Just like if you've gone through puberty before, just like when you went through puberty the first time, testosterone is the major driver of oiliness of skin and of acne. And people do also find that their skin gets rougher, just the opposite of what you would expect with estrogen. You should get facial and body hair growth. So you should be able to have a mustache or a beard of some flavor. That usually starts around 3 to 6 months. You should get much fuzzier in general everywhere. If you are going to get what's classically called male pattern baldness, so losing the hair on the top of your head, that usually kicks in long after a year. But really, again, look at your closest genetic relatives for whether or not to expect that. You should get increased muscle mass and increased strength. Part of that is because testosterone increases your muscles themselves. And some of that is the strength from having more red blood cells and more ability to carry oxygen in your blood and feed all of those muscles with all that extra energy. Kicks in by 6 to 12 months. Again, just, usual puberty time course, 3 to 5 years. Your body fat should redistribute to a more classically, quote, male, unquote, pattern. And if you currently have periods, they should stop. By 2 to 6 months is typically where most people find that their periods will stop. And I'll get into a little bit more detail about that a little bit later. But yes, most people do find that their periods go away. Most people also find that they get sort of dryness and thinning of the vagina, side effect of testosterone. So that usually kicks in by 3 to 6 months. And then also the voice will drop. Some of these effects are permanent. So losing hair on your head, that's permanent. Gaining hair on your chin or on your upper lip, that's permanent. That can be removed later with electrolysis or laser if you so choose, but it is like once those follicles have developed, they stay. And then the deepened voice as well. Actually, I skipped over one other change to expect too, and that's the clitoris will also get larger. And that's actually super handy in some of the surgeries later for those who are interested in surgery. So those are some things to expect. If you go off testosterone later, then your period should come back, your body fat redistributes, you lose a lot of muscle mass, etc. So does lots of things. Awesome. But what can't testosterone do? It's not a magic pill, so to speak, that will change all of the things. So testosterone cannot change your height. It, in general, doesn't change your bone structure much. So, if you have that wider hips, that the bones in your hips are actually, shaped in that more classically female hip structure, it can't change that. If you have developed breasts, it cannot remove them. You will need surgery to remove those if you need those. If you need those removed, and obviously, it can't, give you a 9-inch long penis. There are some changes that happen with the genitals, but you'll need surgery if you want to actually really change your genitals. And testosterone cannot prevent pregnancy. I'm going to say this 5 million times, but it cannot prevent pregnancy. You can still ovulate, you can still release an egg, you can still become pregnant while on testosterone. So we talked about the benefits. So we talked about what it can't do, unfortunately. What are some of the risks of testosterone? We saw this table when we were talking about feminizing hormones before. And so the parts to pay attention to are the red boxes. So the risks that we know that testosterone causes, the big ones in bold, polycythemia. That's where you make too many red blood cells. So testosterone will make you make more red blood cells. It's why if you look at your blood tests, there's a male range and a female range, big giant quotes here, for how many red blood cells you have in your body. That's not actually just because of periods, that's because of testosterone. So sometimes testosterone makes you make too many red blood cells, makes your blood super thick, causes badness. Not a good time. Polycythemia can lead to clots and all kinds of other awfulnesses. So we do check for it. Can make you gain weight, causes acne, causes balding, and does increase the risk of sleep apnea where you stop breathing at night for short periods. That's really more related to the weight gain than anything else. So we know it does that. It probably does some things with your cholesterol levels. It probably does some things with some liver enzymes and some other stuff. Like, we think it might do these other things, but really what we don't know is whether or not that actually increases or decreases your risk of a heart attack down the road. We have some guesses, but really, I wouldn't necessarily, say that you have a higher risk of a heart attack, because we've never done the research. And then we have absolutely no idea what testosterone therapy would do for your risk of breast cancer, cervical cancer, ovarian cancer, or uterine cancer. We just don't know. We just haven't done the studies. So lots of unknowns. From my perspective, medically, though, all of those unknowns, sure, I don't know exactly what those risks are, but I do know what the risk of not taking testosterone is, and so I'd much rather folks be on the testosterone than not if they need it. So, types of testosterone. If you remember when we talked about estrogen, there are 20 million different forms. So there are 2 for testosterone. It's either you inject it or it goes through the skin. There are some reasons why we cannot give testosterone specifically. We cannot medically give it if you are pregnant or may be pregnant. And that's because testosterone will not just masculinize you, it will masculinize a fetus. And so medically we can't. The other thing is that if you've got active, like estrogen sensitive breast cancer, not likely. But the reason for that is because all estrogen in the human body comes from testosterone. And so actually when we give testosterone, we increase your estrogen level a little bit, and that can feed in the cancer and make it grow. So we can't do that. Got to treat your cancer first. There are other things we can do to help with the whole estrogen situation, but we can't give the testosterone. If you have things like liver disease, polycythemia, you have a history of a heart attack, stroke, diabetes, all that other stuff, then we use with caution and we control those other risks. But it doesn't mean you can't have it if you have liver disease, have testosterone if you have liver disease. So injected testosterone, it either goes into the muscle, typically the thigh, just like the flu shot, only it's in the thigh. Some people will give it in the butt, but I can't. Usually what I do is I train people to inject themselves. And I don't know about you, but it's really hard to reach around and inject yourself in the butt. So I usually do the thigh. Or you can do what's called subcutaneously. If you have any relatives on insulin, that's how they give their insulin. So you give it underneath the skin. Cutaneous means skin, so underneath the skin and underneath the fat, basically, that's underneath the skin. You can inject every week, or you can inject every other week, kind of your choice. In Europe and outside the US, they have some forms of testosterone that are every month. Those do exist here in the United States, but they're much more expensive and you need to sign up for their whole like cost saving program. And I generally don't jump through all those hoops. Most people are fine every week or every other week. I tend toward every week, just for the same reason that I do for estrogen, which is that sometimes people feel really awful toward the end of those 2 weeks as they run out of testosterone, so to speak. For those who are not interested in needles or are really scared of needles, the version of testosterone that goes through the skin is the other option. Comes as a gel or a cream most commonly. You do need to apply it every day. Sometimes gets a little messy. And you cannot let the gel or cream touch anyone else, particularly anyone who could be pregnant within your household. So it can be a little challenging sometimes to apply. A while ago, there are some other like really fancy forms. There for a while was something called Axiron on the market. I think it still is. Goes on the armpits, like deodorant. You put it on before you put your deodorant on in the morning. Much more expensive, but they do exist. There's also a patch that exists, again, more expensive, but if you can financially afford it and are having issues with the other forms, you can switch to that. A side note, testosterone is what we call a controlled substance. If you've heard about doping in athletics, they're talking about testosterone. Almost universally with cisgender men, but occasionally also with cis women, there have been some issues. It is a drug that is tested for, so to speak, if you're a professional athlete. So a controlled substance means the federal government basically is looking over all of our shoulders and has made some rules about how physicians can prescribe it. It's what's called Schedule 3. So basically, you have to have a new prescription every 6 months. And I, as a physician, can only give 5 refills at a time. So I have restrictions about how I can give it. Kind of a pain in the butt. But it's how we have to give it. So that's how we do it. Other medications that may be relevant or useful, other than testosterone, obviously what we call the GnRH agonists or puberty blockers. Those are the injections or implants which completely suppress a person's sex hormones. It completely shuts it down at the level of the brain. We use these most commonly in trans folk for trans youth, in particular those who are starting to go through puberty. And we use it for two reasons. And in a later lecture, I'll kind of go more into these details, but either to buy us time as we talk to family and kind of get everybody on board for doing hormone therapy, or we do it basically so we can use a lower dose of the hormone that we're using. If we're able to use a puberty blocker, then the dose of testosterone or estrogen we have to use is much lower. It's expensive. It is covered by insurance. It is expensive, but works really, really well. The other thing that might be useful are what the DHT blockers that we talked about a little bit when we talked about feminizing therapy. So basically, finasteride and dutasteride, these are medications that for someone who's wanting to masculinize, you could think about if you're getting the hair loss, the male pattern balding, and if it's really bothering you. We use them in cis men for this purpose. It's also useful for prostate-related issues in people with prostates. But, you know, it could be helpful for the whole hair thing. There are a couple of other types of medications which you could consider using in special circumstances. There are medications that block estrogen specifically. I'll be honest, that's way outside where I normally practice, and I would probably end up referring to someone with more experience with those medications. They're not commonly used. They're mostly used for like estrogen sensitive cancer. So I mentioned earlier that with testosterone, your period should go away. Unfortunately, it's not the case for everybody. It goes away for most people. The rule of thumb is if your periods stop on testosterone, and they do for the vast majority of people, they should stay gone so long as your dose of testosterone doesn't change. So if you stay on the same testosterone, you don't miss a dose, you don't get a dose late, you should not bleed again. If you bleed again, you need to call your physician and you need to get that investigated. There have been a couple of cases of things like endometrial cancer, which is cancer of the lining of the uterus, and other uterus, ovary kinds of cancers and issues that can sometimes the only way they show up is with vaginal bleeding that looks like a period. And so as a physician, I need to know about this so that I can rule out cancer. That means so I can say that you do not have cancer. Once we've said, okay, you're bleeding, but it's nothing bad, it's breakthrough bleeding, then we can kind of go down the rabbit hole of ways to make your periods stop. We can make your periods stop. If you need them to stop, we can make them stop. There are 20 million different ways we can do that, and I'll talk about that in a second, but just so you know, we can stop the bleeding. But sometimes testosterone itself is not enough. Pregnancy prevention. Did I mention I was going to mention this? I'm pretty sure I did. Super, 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 super important. Pregnancy is an absolute no-no while on testosterone. Testosterone is what we call a category X drug. Physicians absolutely cannot give it if a person is pregnant. So testosterone will lower the chance of becoming pregnant, but we have good data, we have good studies, we have proven that you can still ovulate while you're on testosterone, you can still release an egg, you can still become pregnant. So what kinds of pregnancy prevention can you use if you need to while you're on testosterone? I'm going to link bedsider.org is my hands down favorite resource for patients for talking and looking about birth control. It is LGBTQ inclusive and it's cute as all get out. I love it. So those are some of the images of some options, and we'll go through the options real quick. You probably got a lot of this when you did sex ed, but I don't know about you, when I got sex ed, even in medical school, it really wasn't trans inclusive. So what I can tell you is if you're on testosterone, all of these options are available to you. All of them. We used to say to avoid the ones that had estrogen or progesterone because, ooh, maybe it'll make your dysphoria worse, or maybe it will increase the risk of clots. If it's this for the form that's going to work best for you, that matters a whole heck of a lot more. So all of these options are available to you. The ones that I have starred, and I'll go through them, are the ones that they're what are called LARCs, long-acting reversible contraception. Set it and forget it, and they are the most effective methods that we have. So, except for surgery, obviously. So non-hormonal methods, condoms, spermicide, generally best together, not the most effective, but they absolutely work. And condoms and other barrier methods are the only way to prevent sexually transmitted infections. The withdrawal method actually does reduce the risk of pregnancy. I would never rely on it, but in a pinch, that plus another method could be really helpful. And then there's the copper IUD, which I have a picture of here. It's called the Paragard is the brand name. No hormones, just the copper itself is enough. Long-acting reversible contraceptive, the second most effective form of preventing pregnancy, period. And then there are the various surgical options. So there's the tying your tubes surgery, so to speak, which leaves the ovaries and the uterus there, but cuts the connection between them. Or, take the ovaries out, take the uterus out. Can't become pregnant if you don't have a uterus. It works really great. Take the vagina out. That way you're not using it. All of the surgical options will make it so you can't become pregnant. There are the progesterone only options. So that's the Nexplanon, which is the little implant that goes in the arm. That goes in for 3 to 5 years, depending on your weight. The progesterone IUD, also on an image here. Brand names are the Mirena, the Liletta, and the Skyla. The Mirena and Liletta are basically the same thing. That lasts for 7 years, and it is the hands down most effective form of preventing pregnancy, aside from taking your uterus out. It is more effective than the sterilization surgery, the tying your tubes surgery. And the Nexplanon and the Mirena, the progesterone IUD, can stop your periods. Super helpful. Then there's Depo, which is an injection every 3 months. The mini pill or Micronor pill, which is progesterone only. And then there's the combination stuff, the pill patch ring. So combination pills, which you don't have to actually take the placebo week. You can just take the hormone continuously and therefore not have a period. The patch, same thing. And the vaginal ring. So there's a ring that you can put in your vagina, which that may also be helpful if you're struggling with vaginal atrophy. And then there's your in case of emergency options, your Plan B or Ella, which is the pill that you take after, like if the condom breaks or, oops, didn't mean to do what I did. Plan B, it will help prevent any fertilized products from landing on the edge of the uterus and implanting and becoming a pregnancy. The copper IUD can be placed actually as like a Plan B. It's more effective than Plan B. And then obviously all of your pregnancy termination options, which are a whole different talk. So a typical regimen for me, I typically go with testosterone cypionate just because it's what I'm most familiar with. I typically recommend people inject either in the muscle or under the skin. Whichever they prefer, really, people can kind of play with it. There's no reason to stick to one forever. And I typically recommend once a week injection. If injection is not on the table, then I will go back to the gel. There's really no one typical regimen. That's just kind of what I've fallen on. Monitoring. So as I mentioned, there are some risks. We want to screen for those. So it's really pretty simple. When you start testosterone or when you change your dose, then we want, or increase the dose really, then we want to check what's called a CBC, a complete blood count. So that check, really what we're checking for is how many red blood cells you have, and that's checking you for polycythemia. We check it every 3 months for a year after you start or after you increase your dose. And then after that, it's once a year. We can add other things on depending on your risk, but really that's the most important one. Do we check hormone levels? Historically, we didn't used to. But these days, we typically do recommend that we check your testosterone level, and really your testosterone level only. As I mentioned, we're not getting rid of your estrogen. We have not yet, as a community, decided that is useful for folks. So we check the testosterone level, and really the goal is within that quote, physiological male, unquote, range. So the range that any cisgender man would have, typically. And my goal is to get you somewhere within that range. It is a huge range. It's 200 to 900, and people can be anywhere within that range. And it's a huge range. So my goal is have you somewhere in there, have you feeling better, having the physical changes and the relief of dysphoria that you need, and not having you have a toxic level of testosterone in your body. If you've heard about things like roid rage, from all the athletes who were doping, who were using extra testosterone, yeah, extra testosterone can actually increase aggression. We don't see that in trans people. If anyone tells you, oh yeah, roid rage, no, that doesn't exist for trans people who are on testosterone for hormone therapy. You only get that if you're on way too much testosterone. So I like to make sure I'm not giving people too much. But really, I think as I mentioned in previous lectures, the most important thing is that you're feeling better and that dysphoria is taken care of. I got to plug, how do you reduce your risk? All the same things that probably every other doctor has ever told you. Don't use tobacco products of any kind. Don't smoke cigarettes, don't smoke cigars, don't use snuff, don't use e-cigarettes. Nicotine itself is not necessarily that harmful by itself, but like all of these other products have significant health risk associated with them. Even one cigarette a week, a month can drastically increase your risk of cancer and other problems. Make sure you exercise regularly, at least 30 minutes 3 times a week, which is the CDC recommendation. Eat a balanced diet, variety of food, mostly plants. Try not to eat the fast food and the sodas and the juice, which is just soda without the bubbles. And, try not to eat 20 million chili rellenos. Try to eat only one. Be reasonable. Do your best to maintain a healthy weight, which is super challenging, especially with how things are going in the stress level. And man, those cookies look good, but do your best. Get the blood tests that we recommend. And then if it's relevant for you, remember to protect yourself from sexually transmitted infections and to get yourself and your partner or partners tested regularly. So those are kind of the highlights and all of the things that I felt were really important to talk about in this 30 minutes. But I would love to hear from you guys and what questions, what concerns, what rumors have you heard, and what questions can I help answer for you?
All right. I don't see any questions in the chat just yet. I'm trying to think of questions that I had during the presentation.
I was getting one for a while. We actually had a testosterone shortage. People may have heard of this. It was actually quite the crisis. And it was nationwide. I want to say it was about a year ago. COVID has completely blurred all my senses. I don't even know. I think it was before COVID. There was a manufacturing issue. So that does happen sometimes, unfortunately. And what we were typically doing, the other thing is that the testosterone vials have changed. So people may have noticed that. I used to be able to give people, it was 10 milliliters at a time in a vial, and they decided to stop making those. So unfortunately, by the way, we're now down to like tiny little 1 milliliter vials, and most people's doses are like up to 1 milliliter a week. And so it's like a week at a time vials. It's really annoying. But so people may remember that. Fingers crossed we won't hit that again. But I can say at least that wasn't just a Salinas or a California thing. That was like the whole country. I was seeing a lot of chatter amongst all the other physicians who were doing this. It's quite a crisis.
I do remember that happening with some of my friends who were on testosterone at the time.
Yeah.
That was not a fun time for them.
Yeah.
I was going to ask about like counter indications with other like sort of medications or with even recreational drug use.
Yeah. The major thing, testosterone doesn't interact much with many medications. Unlike, a lot of medications you'll see on the label, for example, don't drink grapefruit juice while you're on it. A lot of medications are processed by the liver or the kidneys. And so sometimes, like with the grapefruit juice, it has to do with different enzyme levels and the way your liver processes different things. Testosterone tends to be less like that because basically we're giving you a slightly modified form of that same hormone. So there's not that much processing your liver needs to do. And I do remember, at least for estrogen therapy, they even did studies with some of the really complicated medicines like the HIV medicines and found that it still worked. So I don't know of any medications you can't combine with testosterone. The recreational drug wise, obviously probably don't use those, but I recognize that many people do. So I tend to do a harm reduction model. So, ignore the don't do that. That never works. I don't know why people still say that. So the things that I think about the most, the drug, so in terms of recreational drugs, I think there are a couple of ways you can reduce your risk. One is try to stay away from the ones that you need to inject. And if you choose to use ones, or if you're struggling and really just have to use an injection one, make sure you're clean about the way that you inject. As much as you can, get clean needles, clean the area before you use safe injection practices if you can. And I think, if you, for example, are snorting things, then don't share that implement either with other people. So if you use a straw, don't share that. Sharing anything that you inject with or that comes in contact with blood with anyone can actually spread HIV. So that's a not known fact, is the snorting things up the nose. The other major thing that I think about are the substances that really impair your ability to think clearly and could lead you to do dangerous activities. So if you choose to use something, if you choose to get blackout drunk one night, make sure someone's watching your back so that you don't go do something that could make you pregnant, for example, and cause you more, or go driving and cause you more issues down the line. So I think there are safer ways to use medicines, and those are a couple of the ones that come to mind.
Right. And that's across the board too.
Yeah, I don't care if you're on testosterone or not. This counts for everybody.
Another thing I was going to ask about is for people who are assigned male at birth, is there like testosterone therapy for them based on certain factors or anything like that?
Sure. So absolutely, for people assigned male at birth, there are a couple of things. One is you can always have intersex people who were assigned male at birth, who have different levels of hormones or have different anatomy or different receptors as well. So for them, absolutely, testosterone plays a role. It just depends on what the particular difference of sex development that they had was, and that's a whole topic in and of itself. The other things that I think about are, for example, you can have young folks who are assigned male at birth who get testicular cancer and need their testicles removed. Or sometimes other conditions can lead to a low testosterone level. I'm sure everyone's seen the ads. It's not as common as the ads make it out to be. It's actually pretty uncommon to naturally have really low testosterone levels, but it totally happens. And a lot of AMAB people feel much better when their testosterone level is in the physiological range. So no, absolutely, it plays a role. And most of the products that I use in my trans patients were designed initially for cis men.
Right. But like, in terms of someone thinking, oh, if I go on testosterone, I'm going to have a fuller beard, or I'm going to grow more hair, like on the top of my head, that's not necessarily true, but...
No, so just like with estrogen, the more testosterone does not mean you transition better or faster, nor will it necessarily do anything for cis men. If you have a normal testosterone level and for example, you're struggling with erections, more testosterone is not going to fix that. It's definitely not going to help with the beard. Some people just do not grow good beards. Sorry.
Yep. It is what it is, right?
It totally is. Go find a different style.
Right.
I look fabulous without a beard.
Let's see. Still not seeing any questions. I wanted to sort of open it up to any recommendations you might have now that vaccines are becoming more readily available for COVID-19.
Recommendations for just hanging out.
Just sort of like how to go about it.
Yeah. Oh, for getting the vaccines. Yeah. Definitely. So first of all, people talk about which vaccine should I get? Get the one that you can get first. Yep. They all work. They're all safe. Go get them, please. Unless you have one of the actual contraindications, which is really rare. It's like allergy to stuff that's in the vaccine. And I don't know how you would know that you have an allergy to the thing that's in the vaccine, because like the Pfizer one, I just looked at the ingredients today. It's like bits of RNA, which you're not allergic to, I guarantee it, and like potassium. There's like nothing in it besides the mRNA. Anyway, but we say that about everything. If you have a true allergy, don't get it. Talk to your doctor if you have other concerns. How you can actually physically get the vaccine is still being really challenging. I believe Monterey County has a website. I've heard it's super hard to use. I know that my own clinic, we're going through the list of patients and calling people and having them come in for appointments. Your best bet is to look at the county website, which is a pain in the butt. Or I think there's a website, My Turn, for California, that also says when you're eligible. Starting, I believe it's on the 17th of this month, people aged 16 and over with specific health conditions will be able to get vaccinated. Some people are able to get vaccinated sooner, but that's sort of the limit. And so people who with obesity, with diabetes, with HIV, definitely, oh man, are all getting vaccinated. So there's a full list that you can find on the county website. Once the Pfizer and Moderna ones are 2 shots. The Johnson & Johnson, I believe, is 1. The ones that have the 2 shots, I'll warn you, for a lot of people who have gotten the vaccine, the first one is pretty benign. You feel just fine, like a flu shot. And then some people with that second one really feel like a truck hit them. And I did too. And it's a bit of and really what that feeling is, you're not getting sick. You didn't just get COVID. You didn't get the flu. It's nothing like that. What you're feeling is your body revving up to fight the disease. So the way that I think about it and the way I describe it, vaccines are like showing your body a picture of a dead enemy. Hi, cat. What the vaccine is doing is showing you a picture. Cannot infect you, cannot hurt you. But then your body goes, oh, that's the enemy. I have to attack the enemy. And so it gets all of its troops ready for war. What you're feeling, that tiredness, that like, oh, I just don't have the zip and man, I need to go take a nap, which is how I felt the second day after I got my second shot, is your body revving up for war. It's putting all its resources into that. Excuse the cat in the background. And so just be prepared for that kind of feeling, really, with any vaccine. It's okay if you have a bit of an elevated temperature. You do not need to treat that. Fevers actually don't hurt you. They actually help you fight the infection, but they generally feel miserable. So if you feel miserable with a fever, probably treat it, but you don't have to treat a fever, by the way. So those are my initial thoughts. The other thing is to pay attention to the CDC recommendations. The CDC did release specific recommendations for what people who have been vaccinated should and shouldn't do. We are still recommended to be masking and social distancing. We can visit with other vaccinated people at this point in small groups, like you can go visit your friend, but gatherings are still basically a no-no, because what the CDC says is to follow your local guidance, and we're still in the purple tier. We're barely in the purple tier, but we're still there. So like indoor big gatherings, even of completely vaccinated people. So there's just some thoughts off the top of my head.
Yeah. I know like a lot of people will hear, oh, there's a vaccine available, and they'll, well, someone will say that, and then they will hear, oh, it's a cure. And that is not what a vaccine is at all.
No.
So yeah, we're still recommending staying masked, social distancing 6 feet, trying not to gather in big groups. None of that is going to change anytime soon.
And that also doesn't mean the vaccines are ineffective. The vaccines are actually very effective. They're amongst the most effective vaccines. Part of why this, in my opinion, has nothing to do with what the CDC has actually said, in my opinion. Part of why the CDC is saying this, one, is out of an abundance of caution. If you wear a mask and stay away from people and don't hug your best friend, you will feel sad. But if you hug your best friend without the mask and you turn out to have had COVID, you could have just killed their grandparent. So like the consequences of not masking, not social distancing are so severe that it's worth that extra caution to help make sure that our loved ones don't die. And I know it sounds like I'm being dramatic. I'm not. It kills people. And so it makes sense to be extra, extra cautious. The other thing is that a lot of the recommendations for continuing to mask are in public spaces. We want to encourage everyone to still mask public places because it's not like I have a giant vaccinated sticker on my forehead. And we want to continue to have a culture of, yes, we mask, yes, we care about each other, yes, we will keep from killing each other with this virus that we don't know if we have or not. So in my opinion, that's part of what's going on with that. The other question that I get sometimes is, I had COVID back in months ago. Should I still get the vaccine? And the answer is yes. Once you're about 3 months past having had the COVID infection, you can be infected again. That is not true of the vaccine. And so the vaccine is what's going to give you long-lasting immunity. And I'm sorry you had COVID.
Yeah.
And I'm glad that you're alive.
And is it true that you could be vaccinated but still be a carrier?
That one, I have to go look at the data, and I'm not entirely certain. We were worried about that for a while. The last thing that I heard is that we think that you don't carry it as much, and that it actually really does prevent transmission, but I haven't seen the latest data, so I'm a bit behind the curve.
Okay, so it's not necessarily yes or no. We're not 100% on it.
Well, nothing's 100%.
Yeah.
It sounds a little flippant, but no vaccine is 100%. Mm-hmm. It just isn't until of course you eradicate the disease, which is why nobody has smallpox anymore, which is great.
Yeah, and there's always going to be a variable too. Like there's always going to be an exception to the rule, like just because every human being is not the same. So yeah. All right. Yeah. Well, I don't see any questions, so I guess we can just sort of wrap it up.
Sure.
Thank you to our viewers. Thank you to Dr. Rose. Thank you to my colleagues Haley and Sam for their support. We will be back on April 15th, Tax Day, with another live stream of QT Health 831. And with that, we'll go ahead and say goodnight.
All of you stay safe.
Wash your hands.
Wear a mask. Get vaccinated.
Drink some water. Like more water.
Also, get some sun on your skin.
That.
Vitamin D deficiency is a real thing. Like, get some sun on your skin for 15 minutes and then put the sunscreen on.
Perfect.
Absolutely.
Have a good night.
All of you stay safe.